Hello, and thank you for joining me for this video series on cardiovascular kidney-metabolic syndrome, or CKM. I'm Viet Le, an Associate Professor of Research and a Preventive Cardiology PA at Intermountain Health in Salt Lake City. Over the course of 4 short videos, we'll cover the root causes and staging of CKM, as well as the connection between the heart and kidneys. Then, we are going to review 2 patient cases to discuss diagnosis and treatment. Let's dive right in. CKM syndrome is a progressive condition spanning identifiable stages across the life course, from metabolic risk to subclinical and clinical cardiovascular disease. CKM syndrome is not just the name of a disease, but rather a clinical framework for earlier risk identification, integrated prevention, and coordinated management across cardiovascular, kidney, and metabolic domains. It requires us to move away from managing individual heart, kidney, and metabolic dysfunctions separately, and instead think of them as components of an interconnected syndrome that affects multiple organ systems with the goal of intervening earlier to prevent irreversible disease progression. CKM syndrome is a growing public health concern. Data indicate that approximately 90% of US adults have at least one CKM risk factor or have stage 1 or higher CKM. In fact, approximately 55 to 60% of adults have stage 2 or higher CKM. Because this syndrome occurs at the intersection of cardiovascular, metabolic, and kidney disease, we need to be aware of the risk factors for each condition individually. Routine assessment for metabolic and kidney risk factors is recommended for all adults, and selected assessments for pre-heart failure, MASLD, and obstructive sleep apnea are recommended for some individuals. We should also assess social determinants of health, as these are closely linked to CKM syndrome. You can take a look at the recently updated 2026 Clinical Practice Guidelines from the American Heart Association, American College of Cardiology, American Diabetes Association, and American Society of Nephrology for more information. You can also check out the AAPA CKM Syndrome Toolkit. Screening helps us understand whether a patient is at risk of developing CKM and to stage the CKM if they are already experiencing it. This image, originally published in 2023, has now been carried forward into the 2026 Multi-Society Guideline to illustrate the stages of CKM syndrome. As you can see, any patient with excess or dysfunctional adipose tissue is already in stage 1 of CKM. And I think most PAs in primary care notice that this makes up a substantial portion of our patients. So here's a question. For those patients, are you documenting stage 1 CKM or higher in their chart? I think for a lot of us, the answer is no, or at least not always. The 2026 guidelines really call on us to take action using the tools available to us and our best clinical judgment to get ahead of cardiovascular disease and focus on prevention and provide those ICD-10 coding guidance to support this documentation and risk identification. So how can we get started building this into our daily assessments and documentation? CKM screening is informed by stage and risk, with the goal of identifying where a patient falls along the CKM spectrum, monitoring progression, and guiding timely, personalized prevention and treatment strategies. As the CKM stage advances, the intensity and scope of screening expand to support more precise risk estimation and to inform interventions that can preserve cardiovascular, kidney, and metabolic health. Many of the screening modalities we use are common in primary care. It just requires us to put the pieces together for a complete picture. The AAPA CKM Syndrome Toolkit provides a comprehensive overview of screening tools and their recommended cadence for us at each stage of CKM. In general, for screening at stages 0 and 1, we will focus on risk identification using anthropometrics, blood pressure, and basic laboratory tests. Our goal is to interrupt progression of CKM before organ injury. Once a patient has progressed to CKM stage 2, we will focus on organ involvement. Now we are doing at least an annual UACR test, which measures the ratio of albumin to creatinine in the urine, we're also increasing metabolic surveillance. In stage 2, any kidney damage is often subclinical, but still alters cardiovascular risk. In stage 3, we aim to detect subclinical disease and reassess risk using coronary artery calcium, cardiac biomarkers, and targeted imaging. We're also escalating therapy. In stage 4, we have shifted entirely from screening to management, with a heavy focus on monitoring established cardiovascular disease. Screening tests guide prognosis and treatment response and allow us to detect complications. Additional testing after therapy initiation or titration is recommended to optimize cardiovascular and kidney risk reduction in stages 2 through 4. CKM progression often starts silently. Patients can feel completely well while cardiovascular, kidney, and metabolic injury is already developing underneath the surface. So now that you understand what screening looks like, I'll hope you will join me for the next video where I'll discuss why some of these screening tools are so critical and what they tell us about organ involvement. See you there.